So it's great to have Keith with us today. He's a man of many talents. He's actually a professor of orthopaedic trauma surgery at the University of Oxford, and he's been an NHS consultant a couple of years longer than I have. So he's actually got experience in trauma care and teaching, both nationally and internationally, and widely spread across the NHS. He's actually founded many things. He founded a children's safety charity, which raises safety awareness in children, and they've had their 20th birthday this year, I think. Is that right, Keith? And they're at the Kanduri Centre for Critical Care Research and Education. So he's done a whole host of things. And because of that, actually, in 2009, he was the first National Clinical Director for Trauma Care at the Department of Health. And when I first came into clinical practice as an anaesthetist, I remember actually one of my jobs was 2 sessions of a trauma list, treating trauma that had come in the night before. In fact, I should say I did the only 2 trauma lists in the whole hospital at that time, treating people with fractured necks or femur. And really, when we look back, we did not a very good job of that. And Keith has been instrumental in sorting out nationally the care pathway for people who fall and damage their hip. He also set up regional trauma networks, and he was instrumental in creating the major trauma centres, which we know evidence-based is the right thing to do. In his current role, he's the national medical oversight for all acute services in the NHS. That's not just A&Es or anything else, but it goes through maternity, it goes to the armed forces, it goes through disaster planning and so on and so forth. And he's leading the transformation of urgent and emergency care across the whole system. So it's with great pleasure that I actually do the next bit, which is in 2016 he was granted the CBE for services to healthcare, which I think is well deserved. So would you please give a warm welcome to Professor Keith Willett.
Des, thank you very much for that. And to be honest, I'm just one of you. I'm a member of the public. I'm a patient. I'm a clinician working in the health service. And if you cut me open, a bit like a stick of rock, you'll find NHS right through the middle of me, because that's my passion, is to do the right thing for patients. And I've spent my clinical career looking at patients, always being very critical of the way we offer services to the public and what patients are getting, and I've spent my life really trying to either change the medical model so that and the care model so that we do offer the right care, but also the systems in which we are asked to work and how we need to keep on changing those to meet the needs of the patients that we're there to serve. So what I want to do is, this is an open discussion. This is not a lecture. I don't want it to be a lecture, so I'm going to wander around. If you want to interrupt me, talk about something, please do. I'm just going to walk you through a little bit of sort of the national direction of what we are trying to do, and then obviously you have a local reflection from Bassetlaw or Barnsley or Sheffield or wherever you're from as to what it means in your locality, and you're the experts on that. You're the local population, you're the local health care delivery teams, and I wouldn't want to suggest that I know better for you. But I do think we need to be very realistic about where we are, and the 5-year forward view is the NHS policy on how health services need to change to meet the needs of patients. And back in 2012-13, the Secretary of State wanted us to look at the fact that there was a quite clear trajectory that urgent emergency care services across England were struggling. Whether that was general practice, whether that was in the ambulance service, whether that was in our hospitals or in the community. And I was asked, having, as Des said, introduced the major trauma networks and major trauma systems and those pathways across the NHS, which turned out, and it wasn't me that did it, it was the clinicians, the nurses, the doctors, the therapists, everybody in the system that delivered it, probably one of the most effective healthcare shifts we'd had in the country, and that's been borne out very recently with sadly with the terrorist incidents, when every patient who arrived in hospital survived and every patient went to the right hospital first time. And I can tell you, I did the IRA bombings in the 80s, and that certainly didn't happen then, and it hasn't happened with incidents before. And we now, within 3 years of doing that, between 2012 and 2015, to give you an example of what getting the system right for patients is all about. So between 2012 and 2015, your odds of survival after major trauma improved by 25%. And do you know what? We could have done that 20 years ago because the evidence hasn't changed. But Professionally, a lot of clinicians wouldn't let it happen. Publicly, a lot of people found it very difficult to understand why taking someone to a hospital a bit further away would be good, and the politicians wouldn't let it happen. And it took us 20 years to make that argument, and then when we did, suddenly we look back and find that for a good few years we're guilty of probably more than 600 patients a year dying unnecessarily because we didn't make those changes. So, and this is not about reorganisation for the sake of reorganisation, that's about changing clinical pathways and practice because we know what we should be doing. And the difficulty we have is just how much things are changing. Very often the healthcare system is just reactive because that's what we see as headlines. And I bear a fair brunt, don't I, Joe, of taking the media interviews on. And I will never apologise to the NHS because everybody in the NHS is trying really hard and doing a fantastic job. But we do need to understand why some of these things are just not working. And I've really mucked up your camera, haven't I? Because I keep walking around. And that's your problem, not mine. So keep you fit tonight. So that's, this is what we face all the time in the media. And with a universal healthcare system that we have, which is unique in the world, we are the only tax-funded universal healthcare system in the world. That means it's always in the political agenda, and we won't get away from that. And we just have to keep our focus on our population and our patients. And one of the interesting things is around how our services have changed over time. If you look at the 11 most developed countries in the world, and you look at the Commonwealth Fund, they will show that the NHS in England is still the most accessible, cost-effective and efficient healthcare system in the developed countries. And that's despite us now spending the least amount of money of any of those OECD countries. To give you some idea of the spectrum, we spend 9.9% of GDP, that's all the money that comes in and out of the country, on healthcare. Most of Europe spending around 11%, and the United States, bless it, even without Obamacare, is currently spending 17.8%. So they're spending almost twice what we spend on healthcare. And the reason part of the efficiency has come through really good clinical practice and the hospitals, the primary care, all the services changing to meet what's been a significant change in patients. So in my career, things have changed enormously. And what has happened over recent years is part of the efficiency in the NHS is because we have serially reduced the length of stay of patients, particularly those who are having planned procedures. So there was a time when I trained as an orthopaedic surgeon where if you had a knee replacement, you spent 2 weeks in bed in a plaster afterwards. That's no advantage to the patient. Physiotherapists certainly wouldn't thank you for the stiffness in the knee afterwards, and no advantage for the system. So things have changed enormously. So we've made a lot of efficiencies there. We've also done it in emergency care to a lesser extent. And what that has done is that by not using so many beds in the NHS, in the traditional old system, it's meant that we've been able to absorb each year the increase in demand that comes with the ageing population, particularly as people get older. But also, we've been able to take some beds out of the system, which have made the NHS even more cost effective. And at the end of the day, the taxpayer has a view. And I know that will vary. So that's what's gone on in this. But we've increasingly in recent times, we've had a long period now of limited growth in the NHS, and it's become increasingly more difficult to do that. And we've had to really start to understand a lot more about what the asks are of the NHS in order to satisfy the population. And we've, for a long time, had a disproportionate focus on the hospitals, mainly because that's where most of the money is spent, but it's not where most of the problems occur. So let me give you a sort of a clinical scenario, which is a really common one. So we can have an elderly patient who gets into trouble at home in some way with a health problem. And very often, our elderly population now, our elders in our society, have quite a few healthcare problems at the same time. When I was a junior doctor, and we're talking 3 decades ago, most people came to hospital or came seeking an opinion about one medical problem. Now, most people come with a medical problem or a problem that's overlaid on several. A lot of people now, so the average patient admitted to hospital now is over 75, and most patients will have 4 things wrong with them at least. And that makes a very different patient. And what it means is we have, the world we have to live in and the public we're trying to serve in the health service and the care sector as well is a much older population. And that population often has a lot less reserve. So they get an illness, which might be quite a minor illness, and that illness may well not need hospital care, but what it certainly does is their care dependency, the amount of support they need, suddenly increases dramatically, because they might become a bit confused with their waterworks infection, or they might find they can no longer just manage to get out of bed and get themselves to the cooker and make themselves food. Suddenly they go from someone who was actually coping or with limited support, they just get a cold and suddenly they're changed. And the problem we have in the NHS, in the healthcare, as we've structured it, because it was designed that way to fit how we used to work, is that our default when that happens is to move a patient to a higher acuity, higher cost setting, which is usually the hospital. And then the patient arrives in hospital, and actually, for that patient, that's really not very often the best place. We know that if we put a patient into hospital for 10 days who's elderly, over the age of 65, then they're at increased risk of falling because it's a strange environment. They're at increased risk of disorientation and because, again, the environment has changed. They're at increased risk of infection because they're now exposed to bugs and organisms that they wouldn't do. Their inactivity reduces their muscle strength. And we know that if you put someone in a hospital and essentially immobilize them because they've got no reason to move and walk around even doing the basic things, after 10 days, they are 10 days older in terms of their muscle ability, and every physio will tell you that. So a patient will go in age 75 and come out with the muscle strength of an 85-year-old. And whilst they might have been coping at home initially, 10 days later, when you get them back home, they now need far more care than they did. And if only we'd been able to wrap something around them, as Des said, in the community, we could have significantly changed the outlook for that patient. And also, it would have been the right thing to do in terms of spending resources that we know are restricted in there. So this elderly lady, she falls over. I'll give you a nightmare.
Would you mind?
Can you speak into the microphone?
Oh, that's okay. I'm getting it all wrong, guys. I'm getting it all wrong. I'll stand still. I don't stand still very often, as you can imagine. So this elderly lady's fallen over. Now, 20% of the calls that Yorkshire Ambulance get are older people who have fallen over. Very few of those need hospital conveyance because most of them don't become injured. Some of them clearly break a leg or something and do need conveyance to hospital, but the vast majority don't. But can you imagine yourself, you're the paramedic, you arrive, an elderly patient's fallen over, perhaps in a ward and can float flat. First time the paramedics ever met them, they can quite readily do an injury assessment and make sure that nothing is broken. But it's a brave stroke heartless paramedic that just picks them up and pops them in a chair and drives off. Very difficult for not to convey that shaken up, slightly anxious, upset elderly patient to hospital. And at the moment, what can the paramedic or what can we do in the community to respond to that patient who's needs it? So, I mean, if we could rapidly get community input in terms of community health. We might need a mental health assessment if the patient is confused or has dementia and it's the first time that's been identified. Have we got a voluntary sector that can come in and just be with the patient until perhaps a district nurse can come in and assess the patient? Can we get in touch with the general practice to ensure that that patient's going to be picked up by the general practice, the nurse or the GP in the next few days, and is this a recurrent falls issue, whatever. Most of the time, we can't generate that response. So paramedic puts her in the back of the ambulance, moves her to hospital. And the further she moves away from the people that know her, her care institution or where she is in her family, and her medical records, the increasing likelihood is that that patient will be admitted to hospital. And then once they're admitted to hospital, we're in that cycle of now we've got to start a whole new assessment in a strange environment to get her back home. And fascinatingly, the things we need to wrap around her to get her back home are exactly the same things we couldn't wrap around her when she fell in the first place. And in the interim, we've spent 10 days of £400 a day in a hospital bed that's done her no good and the NHS no good. So we need to understand that our healthcare needs of our society has changed a lot. And there's various things we can do in the pathway to try and make those unnecessary admissions avoided. And so when I was asked by the Secretary of State to lead the Urgent Emergency Care Review, I recognised this was really contentious, and each of you will have strong views about what you think of the NHS, what you think of your local services, whether they should be open or not, or what you should be doing with them, what's good, what's bad. And I said to the Secretary of State, I'm only prepared to take this on as long as I can build this in public. This is not something you do behind closed doors in Whitehall. This has to be done with the clinicians that live and breathe this on a daily basis, the patients who are in the system who are seeking that care, and the public who will want to use it at some point. And that was agreed. So we built this in public. So there was an enormous amount of public involvement. And in fact, all the documents and all the ideas we had and all the testing we done, we put out over and over again since 2013 so that people could comment. And we even built the evidence base in public. So we said, this is all the evidence we can find as to what things we need to change. Has anybody else out there got evidence to assist that? Well, we actually came up with two principles. One was that for the urgent and non-life-threatening problems, which are the vast majority of illnesses and injuries that occur, then we need to provide really highly responsive and effective services that are personalised to the patient as close to or in their home as possible. But we also recognise that of those patients who would need to be conveyed to hospital, there were now medically some conditions which previously were untreatable or unsurvivable that now medicine could do things for, but you could only offer it in specialist centres simply because of the expertise and the number of patients involved. And that for that very small proportion of patients, and it is a tiny proportion of patients, it's less than 4% of activity in any district general hospital, then those patients need to be moved as expeditiously as we could to get their definitive treatment in the right place at the right time. And those are things like stroke, heart attack, major trauma, blood vessel disorders where you have major surgical need, and sort of things like paediatric intensive care. And when we put all this together, we said as we looked at it, we had to test everything we came up through three lenses. So if we came up with something that we thought was a really good thing to do, then did that work for patients with mental health needs as well as physical needs? Did it work for the frail and elderly as well as it would do for anybody else? Did it work for children and young people? And did it work for those with learning or physical disabilities? If not, how do we make sure it did, or what do we put in place for that? Because the social determinants of healthcare are very often in those categories, and it's really important that we're sensitive to that. So when we looked across the urgent emergency care system and saw this congestion problem in the hospitals, the difficulties, yeah, we could open loads more beds, we could do that, but actually, do we want dormitories full of old people being cared for in a way that's really not what is right for them? No, we don't. What we want are the right care as in the right places for individual patients and a responsive system. So we looked across, and you can't read the detail on this slide, but essentially we looked at the 5.4 million people who are admitted to hospital every year and said, but for the want of something better at the front door of the hospital, need that patient not have been admitted, but have been preferably treated elsewhere in the community. Of those patients who even get transferred to hospital, of the 9 million ambulance conveyances, how many of those patients, but for the want of something offered better to the patient and the paramedic at the scene, would have been better treated elsewhere or treated more locally? And of those patients who were being referred in by general practice because the GP couldn't access the things we've talked about, how many of those could have been managed in a different way? And actually, the vast majority of urgent and emergency care does not occur in hospitals, does not occur in A&E. 5.4 million people admitted to hospital. Something like 23 million people attend some form of A&E, including minor injuries and walk-in centres. But there are 340 million contacts in general practice every year, of which, if you ask the GPs, they say about a third of them are urgent, and if you ask the patients, they say about 2/3 of them are urgent, but that's the reality. But it's a tenfold plus of urgent care is going on in the community. And if you go to your pharmacists, 440 million pharmacist contacts in your high street chemist, And a significant proportion of those are urgent care. So you can see that we end up having this focus around hospitals and A&E, but in fact, this is a system-wide opportunity to really try and provide a care that's different. And we call that channel shift. So if we look at all those elements and say, but for the want of something better, could we have moved that patient and managed that patient better for the patient, better for the system, further along that line? And so we look at that, and we've looked at all the evidence that would support what were the right things to do and what might work. And what also became clear was if you had a really good idea, an absolutely no-brainer, if we do this, it's bound to improve things, isn't it? Very often when we tried those things and just did one of them at one point in the pathway and evaluated them, they didn't do what we thought they were going to do. And the truth is, this is such a powerful system that even if you have a really good idea but you only do one thing, the rest of the system will just swamp it before you've even evaluated it to see whether it was the right thing to do. And so often we've had really good ideas, evaluated them, and then the poor CCG who funded them turns around and says, well, look, it doesn't seem to have worked. We can't keep doing this. So what we determined and we modelled was that you've actually got to look at every part of the pathway for patients and see what interventions in that part of the pathway. And it will be the compounding effect of all of those that will produce the right outcomes for the system. Because at the end of the day, every healthcare system in the world has limited resources, and we need to use them in the way that's best for our patients in society. And we did this, and we modelled each of some of the key things that we had evidence for that have been shown to work, and looked at all of those, and that's all modelled, that's all out there as information for services. Some will be very relevant to South Yorkshire and Bassetlaw, others you'll have got in place already, and I'm talking to a lot of your clinicians at the hospitals today and the GPs, and the ambulance service. You've done a lot here. You're ahead of the game, so congratulations. But there's, nobody's finding it easy, and there's no suggestion that it's not really tough for everybody. So I'm just going to run you through some of the things. It's not all the things, but to give you some idea of what sort of things we feel really are worth pursuing, and there's a good evidence base behind. And it's some stuff around the 111 call service. There's some stuff around how general practice and primary care works, what we mean by urgent treatment centres and what that sort of urgent access to primary care and general practice looks like. Some things around ambulance services, a bit around the hospitals and getting patients home. So the first thing I want to talk about is NHS 111. Terrible, isn't it? Clunky, nobody likes it, awful. Okay, so if that was your product you were selling as a company, you never advertised it. The only advertising you got was the Daily Mail attacking you every few months with some horrific story. You'd never use it, would you? So explain to me why it's gone from 2 million users to 15 million users in 4 years. So although it isn't good, it's clunky, it's difficult, it clearly is answering a need, and what we need to do therefore is to make it do what the public and the patients really want from it. So we're changing the 111 service. We're building, so rather than before where it was a bit of an advice and direct service, it's now going to move to one where the majority of patients will be able to speak directly to a clinician where they need to. We're currently now up to 36% of calls going to 111 are passed to a clinician, so the patient can speak directly to a clinician. And that does two things. One is it very often will address the issue. The other thing it does is make sure that the patient can access the right care as close to them as possible. And it allows us to be able to book patients in. So rather than just turning up in some queue at A&E, you might be given an appointment slot in an urgent treatment centre or in general practice. And so we've seen that start to have some effect already. So, but to make that work, when you talk to somebody on the phone, first of all, they need to, with your permission, be able to access some of your medical records to make it personal to you, so the clinician that you're talking to can really understand what your best needs are. We say we're building that clinical input, but it's not just about having a nurse on the end of a phone. We know there's really important roles for pharmacists, for the mental health crisis teams, because that's a real issue, dental advice. There's a whole group of health professionals that patients would benefit from being able to speak to get advice, and then get a sensible discussion as to what the right way forward is. We also need for the 111 service to know what's available in the community and what has been set up. And that, we call that a directory of services. And ideally, and this will take a bit more time to do, is that not only can you speak to the clinician, but they can then book you directly into that service at a time, so that you will arrive somewhere without having to queue, and that will be as convenient as you can. So it's got to become the smart call to make, really. And we're already at 36% nationally, and we were asked to hit 30% by March, so we're just about ahead of schedule. Pharmacists, people tend to see them as people who, in the local high street chemist who dish out the tablets. Pharmacists have 4 years of training, so 1 year less than a doctor. Immense knowledge around minor illnesses and ailments, really good around advice around vaccinations, medications, allergies, side effects, all the sorts of things, which often will occupy a lot of 111 calls and GP time, which really the pharmacists are better cited, because I suspect the GPs some of them are checking through their equivalent of the formulary to find out whether that is whereas the pharmacist will know. The pharmacist will know the interactions between medications that perhaps not everybody appreciates and can put things together. So we're increasing the role of pharmacy, because that's a real opportunity, and it is one of the few healthcare professional groups that we actually have enough staff in. Indeed, we have almost a surplus. So very valuable, and we've underused them. In fact, if you look at the old data, last year's data on 111, whereas a significant portion of calls could have been passed to a pharmacist, less than 1% were, and that's something we need to change. And we've also seen the role of pharmacists coming into general practice. Really difficult time in general practice. Demand has gone up enormously. Workforce issues, we don't have enough GPs, they're not going to suddenly appear, and a lot of general practice have really innovated in bringing pharmacists into their practice, because they can manage quite a lot of the asks in primary care. We've also, one of the things when we were building the urgent emergency care review in public, one of the strong things we got was the way people wanted to use the health system. A lot of people, in general, and this is not in any way talking down to the public perception, but the public used to understand three things. I think it's now four when we do our surveys. The public understand what general practice is and what I go to my GP for, but they do rather assume it's 9 to 5, Monday to Friday. They understand now 90% awareness of 111, which is a big climb on where it was. They understand 111 as being that phone call you can make any time of the day or night about a healthcare issue that I don't think I need an ambulance for, but I need. They understand ambulance services, but there's a general public belief that ambulances turn up and take you to hospital, whereas now, in fact, 45% of people, or around that figure, are managed now with the paramedics in the community rather than transferring you to hospital. And they understand hospitals and A&E departments. And so it's silly for us to try and design complex new systems. We need to recognise that that's how the population understand our healthcare services, and we need to just strengthen the way in which we provide those and the offer to the public. So accessing primary care, a lot of the surveys say this is a real difficulty. They either because of the perception that GPs weren't open, or answer phones, as we discussed earlier, that said the GP is closed, and the assumption is that there isn't another option. But only about 50% of people realise there's a 24/7 GP service, and there always has been in England for decades. It's just different to your GP. So it's about making the access to GP. So the GP practices are coming together with extended hours into the evenings and at weekends, and that's all part of that. Some of that's around convenience of getting appointments, but some of that clearly is around urgent access, which is really important. And we're on schedule to have that in place across the whole population by March 2019. One of the other things the public told us when we were discussing with patients was I can give you the figures, we have 485 things, and I'll call them facilities or whatever, that are minor injuries units, walk-in centres, urgent treatment centres, urgent care services, urgent care centres, 485 of them in England, 23 different names. But just because they've got the same name doesn't mean they have the same opening hours, the same diagnostic services, even the same professionals there, or what they can do. And so the public were telling us they were just really confused by this, and they'd either go to their GP if they're open, or they go to A&E. Locally, you might know what your walk-in centre does, But if you're not from the locality, you probably don't. And if you've never used it before, how do I find out when it's open? So there was a lot of confusion out there. Really important services, very valued by the public, but we needed to get some commonality with them so that we could build them into a reactive system so that if you phone 111, they could say, okay, this is what we think is wrong with you. The best thing for you is an appointment in your local urgent treatment centre. So we're looking to try and slowly move towards sort of two descriptions. One is an urgent treatment centre, which is a 7-day-a-week, 12-hour service, GP-led, doesn't necessarily mean there's a GP there all the time, with a range of services that they can offer, and ideally diagnostics in terms of blood tests and urine tests, and the majority with X-ray. And we anticipate having about 150 of those sort of in that category by next March. And then facilities will probably come into sort of more like GP access hubs, which is where federations of GPs or practices will come together and be able to deliver their urgent extended hours access to. So we're looking at trying to get some commonality there. It's not about rigid rules. This is about getting some commonality so it just makes more sense for the system to understand and for the public to be able to experience care offered in a different way and then learn how to use it. We are in the process of changing the way all ambulance services respond in England, and for a really important reason. So if I told you that in England, up until very recently, we're now in the change process, over 50% of all ambulances are dispatched on blue lights and sirens to try and hit an 8-minute response. If I then tell you that less than 4% of people benefit from a response that fast, and what's happened is that as a result of that, the ambulance services are sending motorbikes, sending fast cars, sending 2 or 3 ambulances so that one will get there to stop the clock on the target. But that ambulance may have been trying to get to an old lady on the floor who's not of that urgency, and 2 or 3 ambulances may have got to the end of her road and had to be then diverted to one of those calls. And David Nicholson, who was the previous Chief Executive of the NHS, once said that targets are really good when you're a long way away from them, but when you get close to them, they start to distort behaviours. So we've had ambulance services changing the way they work to try and meet the target and probably miss the point in the process. And that's been a real issue building up in the NHS for a while, and it's making it really difficult for ambulance services to work in the way. And we know some patients have had some very, very long waits because they just haven't been able to get an ambulance to them. And that's been a real issue. So we sat down with the paramedics, with the clinicians and the doctors and nurses in the system. We sat down with the public and patients, and we started again. So we tracked 1 million calls initially and said, okay, this is what you phoned up about. This is what you ended up needing. Did what we send match? And the answer was very often it didn't. So we'd have someone who'd had the clock stopped by a motorbike, but if you've had a stroke, you know, a man on a motorbike or a woman on a motorbike is of no use to you. You need a 2-man ambulance that can convey you to hospital, because what really is important is not somebody stopping the clock in 8 minutes, it's getting your stroke scan inside an hour and getting into a stroke centre for your treatment, your clot-busting treatment, within a certain time. And that's what's important. So some of these things were distorting. So we then looked at all the evidence, we looked at what we learned, and we bring us in. And the reason why so many ambulances are dispatched so quickly is that when you dial 999 and the ambulance service pick up the call, they have 60 seconds to come to the decision about what is wrong with you. If by 60 seconds they haven't reached the decision, and you can imagine a little old man downstairs, his wife unwell upstairs, shouting up and down the stairs, answering questions, 60 seconds gone in a flash. At the end of 60 seconds, the ambulance service had no choice, and it wasn't the person who's taking the call, somebody else in the ambulance service had no choice but to dispatch an ambulance on blue lights and sirens. So we gave the ambulance service longer to listen to that call. And we tested them with an extra 60 seconds, another 60 seconds, and we found the point at which we got it right. And interestingly, despite giving the ambulance service more than 120 seconds, in fact 180 seconds to come to the right decision, the ambulances were getting there just as quick, because we weren't using so many ambulances and diverting so many away from other calls. And it was about being able to send the right thing, the right type of paramedic, because there were lots of types of paramedics, and the right vehicle to what the patient needed. Because there were 6,000 codes. In other words, there are 6,000 things that you could have wrong with you that the ambulance service have to work through. Obviously not all 6,000 of them, but they work through an algorithm and end up with the one. And it's not until they get to the one they think is right for you that they could trigger. And that takes more than 60 seconds. So we've changed the whole service, independently assessed by the University of Sheffield, you'll be pleased to know in your patch, and have shown that that is the right thing to do. Strongly supported by the patient group, Stroke Association, British Heart Foundation, strongly supported by paramedics, and strongly supported by the unions, because this was a real staff side issue in ambulances by the way they were being driven really hard in order to do that. So there's some, and this is what I'm trying to say is we need to be very open about the complexities of healthcare and the ideas that we can change things for the benefit of the system that we're working in. And essentially, no cost. So I wasn't given a load of money to do this. This has happened essentially in-house. There's been another advantage in that paramedics are paid now more, but that's because there's a recognition of the type of work they're doing. And so the whole idea is that wherever we are in the system, that nobody will be working in isolation. GPs will feel it, patient in front of them in the surgery. Paramedics will certainly feel it, patient in front of them. And very often, they have all the decisions to make. And sometimes they would just like to be able to get some clinical advice. So the GP may want to talk to a diabetologist, the paramedic may want to talk to a district nurse. So we need to create a system, whether you're in a specialist hospital as a major trauma centre like the Northern General, or whether you're in a district hospital like Barnsley or Rotherham, where if that specialty or expertise is not in your hospital, you've got someone you can refer to. So nobody is making decisions in isolation. That's right for the patient and it's right for the service, because it means we get patients to the right place. And we've built this into a national system, which I won't go forward, but we have urgent emergency care networks now bringing this together, and this is part of that whole system of just making sure the NHS starts to fit what we need. And the accountable care system that you have an opportunity for, and I'm delighted that you have, is another way of just really trying to engage everybody. You know, the plans that are coming together now, sometimes it's the first time senior executives in health have actually sat down with senior executives in social care or in the community or in the ambulance service. It's bizarre, but that's the way we've been. We've been very fragmented for quite a long time in health. And those relationships and partnerships will start to yield some of these sort of cross-system things that I'm talking about. And where do we end up? Well, we end up with something that's really very different, and it's all about the patient. So we'll end up with whichever way. And patients are really good at making a judgment about what they need and who they should go to. They get it right most of the time. They tend to phone GP with things that GPs can sort out. They don't tend to dial 999 unless it's something that probably needs an ambulance. So they're pretty good at doing that. But we need whichever route, whichever portal, if you like, the patient approaches urgent care in. We need them to take that and then make sure we get them to the right place. If they need to speak to a clinician, we need to facilitate that. And that clinician needs to have their clinical information in front of them ideally, and to be able to book the patient into the right service. So it's not, oh, go to a dentist on Monday. We need to be able to book them in to what they need if it's urgent. We need to try, and we've really neglected what we can do in the community for a very long time in terms of supporting those 340 million contacts, as I say, in primary care, and how do we support better the patient at home with some of the hospital services being much more outward facing. I've talked about the ambulance service and I've talked about the specialist centres. And people talk a lot about we should educate patients, we should educate the public. I don't believe in that. If I tell you that Ebola's coming this Friday, I could get probably 98% of you vaccinated by Friday. If I tell you that this is how I want you to use the urgent emergency care system, as complex as it is, given that each of you on average will attend A&E once every 4 years, you're not going to remember what I've said. And by the way, this time you go with a hurt wrist. In 4 years' time, you go with an unremitting headache. In 8 years' time, you go with abdominal pain. you're not going to know how to use the system. So we have to build the system that fits the way the public understand it and is intuitive. And how will the public then use it, right? Well, all the evidence is through experiential learning. In other words, if I phone 111 with toothache and all I get is, oh, that's bad luck, take some paracetamol and find yourself a dentist, I'm not going to do that again. But if I phone 111 with toothache on a Sunday morning and they say, I'm going to pass you over to my dental team, you talk to the dental nurse and he or she says, well, from your history, this is what I think you've got. I'm going to speak to the best analgesia for that. I'm going to pass you over to our prescribing pharmacist who's sitting behind the 111 service. They raise a prescription for you, tell you that it's going to be available, and this is the pharmacy it's going to be available, which is 20 minutes down the road from you in half an hour. And by the way, I've booked you an emergency dental slot on Monday. Why would you go to A&E? And wouldn't you use that service again? And that's what we've got to do. We've got to start to meet the needs of the public, and that's what this is all about. I'm going to stop at that point. I've got some stuff we could talk about winter if you want to, but that's where we've come from. That's the path we're travelling down. This is a long path. But what I would say to you is that I've been in this game for 40 years. I know I look much younger, and thank you for saying that. But, you know, medicine has changed enormously. 15 years ago, what I used to do in the resus room in A&E, paramedics now do at the scene. Completely changed. We're treating conditions now in hospitals that were unsurvivable, untreatable 15 years ago. The population's changed. We have a right now society. You know, you want a new trousers, you know, you'll go on the next website or whatever your chosen website, then you'll pop down to the store just to make sure they actually what you think they are, then you'll go back and put your code in and you'll get them and you expect them to be delivered. And you expect to do that on a Sunday night? And people have the same expectation of health, and we've got to start to get towards that. And finally, as I said earlier, right at the beginning, our population has changed. So our population, our elders are now much more frail, have much less reserve, have a lot of medical problems, and actually hospitals, not a great place for them. Thank you very much.
And thanks indeed. As ever, that was massively inspirational. Thanks very much indeed. We've had Keith with us all day, meeting clinicians and nurses and A&E staff and people from GP and CCGs, and it's been absolutely inspiring. So please, the floor's yours. Ask any questions you wish of Keith. I'm sure he's... Can you state who you are and where you're from as well?
Hiya, Keith.
Hi.
I'm Liz Mawson. I work in Library Resource Centre in Barnsley Hospital, and I'm a Unison rep as well.
Okay.
I think what you're talking about today is absolutely fantastic, but my worry is how you're going to get enough staff to be able to implement it.
And I think, you know, when I started the Urgent Emergency Care Review, and we were right back at the beginning of 2013, and I went round and was talking to absolutely everybody about what we thought we should do and could do. Three things came out as the biggest barriers, which we have been attempting to address over the last few years. The first one was workforce, and the two bits of that for me. One is about recruitment and retention, particularly retention at the moment, and the other is about morale, because you know we've been beating people up and performance managing for a long time. The second thing was around sharing information. I talked about the importance of sharing patient records and information across the system. I think we got that all wrong for a while, and you know we've got a situation where you know as a patient you can't understand why you go to the GP on a Thursday and they change your medication because you've got a bit of a problem. You phone the out of hours on a Friday evening because you're not feeling quite so well and you think it might be something to do with the tablets that were changed by the GP, and the out of hours doctor can't see the GP records. And then on Saturday you're really unwell and you phone 111 and 111 can't see what the out of hours said or what the GP said. And on Sunday you're really poorly, you end up in an ambulance and they don't know what any of the three said. And when you get to hospital they don't even know what the ambulance said. You know, and the public can't think, isn't this a national health service? So we've got to crack the information one. And so it's workforce information. And the third one, which is perhaps less immediately obvious to you, but from the clinical and the hospital and the performance side, is around how we pay for services.
Yeah.
So at the moment, we have a very, very complex way of paying for services. And that stops a lot of the collective working that you're going to lead as a system here for us. So GPs, as you may be aware, are paid per capita, so they get an amount of money for the number of people on their registered list. The 111 service is paid on a national currency, so they agree how it's paid, but the price is set locally. And when I started, there was a 10-fold variation in that. And then you go to hospital, and that's paid based on activity, and sometimes with a cap. And then you go to the community or to social care, and they're usually on what we call a block contract, which means here's a lump of money up front, do what you can for the year. And come February, when everybody's struggling, they say, well, really sorry, we spent all our money already. So we've got, those are the three barriers. And I agree on the, going back to where you started on the workforce front, it is a real issue. Now, there's a lot of work being done, but it's really difficult. You know, this is, when you start planning workforce, we've often got the predictions wrong as to what we need. We've got, you know, we get the investment wrong so that we don't build enough in. We've lost a lot of staff because of the pressures, there's no doubt. And now what we need to do in the short and medium term is to look at how we use staff. I mentioned the pharmacists. How do we use pharmacists different? How do we have nurses moving into roles that they're more than capable of doing, but have that extended role? Same thing with the allied health professionals, the therapists. And then for the, you know, the limited number of GPs we might have, how do we have them, in my terms, conducting the whole of the orchestra around them, whether they're therapists, pharmacists, nurses, district nurses, so that we get the most efficient system. But I'm absolutely with you, and it's not something that is underappreciated at the national level. But you can't train people overnight, and we've got ourselves in a bit of a mess.
Yeah, and I just want to say also about staff morale. I mean, Richard is working really hard to trying to get staff morale back up, which I'm really grateful for, because he is really trying his hardest. I think morale and the way staff, because they are having to move a lot to different wards, moving away sometimes from the speciality, and that's very stressful. A lot are going on sick. I think if we can try and work on that with clinical staff and nursing staff, about moving around and trying to get the confidence in moving to other areas, because a lot of people haven't got the confidence, and that's what we need to build on.
Yeah, no, I really, I know that is really unsettling for staff, and we have got to, you know, as we become more specialised in hospitals, we've sort of locked our professional groups into a much narrower expertise, and we need to think about that. We've very much gone down the specialist route, which actually, when you look at the patients, they don't come in saying, you know, I've got a heart problem or I've got a stroke problem. They come in with 3 or 4 things wrong with them, but we have to sort of put them in a group. So I think the NHS model needs to reflect that. I mean, in terms of the staff side and how, if we are all work together on this, we can have effect. So the ambulance thing I was talking about, when we changed the programme there, Unison, GMB and Unite were all part of our working that we did, and they came out strongly supportive of the ambulance response programme shift, which I have to say I was very grateful for at the level nationally, because obviously that was important with getting it through government and Parliament, and so that's really important. But one of the things that came out of that was, because they owned that change and they could see how it would start to address some of the real intense pressures they were under, and that they were forever. I've got a wonderful slide of a paramedic, a consultant paramedic, so this is your top level paramedic, who sits in a car and goes off to specific problems. Got a slide of his screen in the car. He was dispatched to 9 different calls over the course of his 8-hour shift and never got to one of them, because he got diverted to another, because something else had got there first, then he got diverted to another, and he never saw a patient. I mean, what a waste. So they knew that the system was wrong, and interesting, going into Yorkshire Ambulance Service, the control centre, one of the things that was said when they started the working on this was the whole level of noise had gone down. You know, that sort of frantic buzz that was going on because everyone was just trying to deliver. So staff side, you know, so I think we need to make sure we're in the process of this, we're improving the staff side.
Hi, my name's Ursula McFarlane. I'm the lead OT at Barnsley Hospital. And
I haven't said OT, have I? I did say allied health.
You did. You kind of got it.
Okay.
It's all right. I'll let you off.
Thank you.
I guess my question, I've got a number, but my first one, I guess, is that we know that the AHP workforce is being developed by NHS England, and Suzanne Rastrick is doing an awful lot for that. And I think what we know is that there are some really good pilots happening around the country. East Lancashire have piloted the project where a paramedic is going out with an OT to prevent those fallers actually making it to A&E. That has shown to sort of be quite successful. And I guess my question is, rather than us all piloting them nationally, how can we just roll those things out as business as usual in terms of, rather than...
I'm going to say something heretic now, aren't I? I said it twice already today. So, do you know what? I've spent a career listening to how do we spread good practice in the NHS, and we just don't do it.
No.
And do you know what? I think it's something about health professionals and the vocational professions. They want to own it because they want to believe it's their model. So what we have to do is, if we put out good practice, people don't, for whatever reason, I don't know, they just very rarely copy it. But what they will do is, if you can give them the data, their data up against some comparator data, and show the impact it's having, then they start to say, actually, we're not as good as them, we don't like this, how can we, and then they might start looking across the fence and saying, well, actually, we could be doing a bit of that. So it's about, you will end up, I think, the local ownership is really important for two reasons. One is people buy into it, and they will make it happen. And secondly, there is always a local perspective to it, how your services are configured, where your leaders are, where your strength is, historically what you've had in the system. So I think there's always going to be a local natural model, which is right and proper. And I think, the CCG model of having local commissioning for a lot of services fits that. But I do think it's a case of identifying the problems, doing that channel shift, looking across and saying, okay, so what haven't we got in place that we could have? And what you're describing is one model of making that rapid response. In some places, the fire service are now going in. We have full services going in other parts of the country to do that role. So there's a variety of different models out there. But, yeah.
I think the other part that follows on from a lot of what you've been saying is that our services at the moment are very reactive. We let people get into crisis, and then, like you say, we've kind of missed a trick, really. So I think something that I'd like to see happening in our local region is GPs having that really easy access to therapists being co-located so that the GP can highlight that person who is having those problems at home much earlier, so that they don't get to the point where they're even falling. And actually we can then hopefully prevent the need for urgent care much earlier.
Yeah, well, I won't ask you if you read every page of the 5-year forward view, but the 5-year forward view had a big piece, a big lead around prevention. But do you know what? Whenever there's ever spare money in the system, we've always reinforced traditional practice. And then when there's no money in the system and we're all struggling like we are now, we've suddenly got to transform everything. And that's the reality. Yeah. So, but then you will find that, we've got a lot of, as the GP practices are coming together and they're doing that, in your area very well and around the country, then they're starting to look at what is the workforce that really delivers for our patients. So the pharmacists, the OTs, the physios, mental health nurse in the practice, they suddenly become really quite effective. But there's a right-sized footprint for that. So because from a commissioning point of view and from a provision point of view, is if I'm going to invest in that, what's my return on that? So what is my saving in the hospital? And if so, how do I release that saving? Because that's part of the payment model I talked about. There's a problem with that. Thank you. But yeah, you're right in there. I've always been a strong supporter of allied health. If you ask my trust, we put 7-day allied health professionals into the hospital in 1994. And our ward rounds in my unit are still nurse and therapy led. They're not doctor led. I've got a badge. Not a Blue Peter badge, it's an OT badge.
There is a conference in a couple of weeks' time that Susan's coming to in Doncaster.
Suzanne Rastro?
Yes, so, yep.
Thank you.
If I'm talking too much, just tell me to shut up.
Hi, I'm Emma. I'm an occupational therapist and I lead the admissions avoidance service at Chesterfield Royal. I think it's just feeding into what you were saying, Ursula. We've tried our best to link with the primary care providers and prevent the crisis point with our frailty unit. So we have an ambulatory care area on the frailty unit and have rapid access referrals from the GP well before that crisis point hits. So we've got geriatrician and ANPs, OTs and physios, and actually our turnaround is really quite high because they're quite easy patients because they haven't reached that crisis point, and we've noticed that the reattendances at ED have significantly reduced. It's still in its pilot phase and I'm presenting at the conference about it. Well, sort of. Got a poster. But it is working really well. So that's something that we've considered at Chesterfield, and it's maybe something that could be considered elsewhere. We've just taken 6 beds off the frailty unit and turned them into chairs, and we've actually noticed that our turnover on the ward has been much more efficient, and our getting people home rates has increased significantly because we've had the right patients.
You've obviously got a good community bit, because what you don't want is to move those patients home and then find they're coming back in. But I would say we tend to look at readmissions as a bad thing, but I would be careful about that interpretation. So if you've got, let's just say you have 10 people on the ward, all of whom are now on that downward slope of being in hospital and shouldn't be there. If you've got all 10 home, but knowing that one of those is going to come back in, because patients don't always do what you want them to do, they don't have predictable recoveries, they have problems. So you set your system up that if that happens, they come straight back in, you're not sort of queuing back through A&E. If you do that, that's a good dynamic system, and I would rather see a 10% readmission rate with a really active policy in getting most patients home and safe, rather than one where you all keep those 10 patients in hospital for 3 weeks just to make sure nobody gets readmitted, because by the end of 3 weeks you've really created yourself a problem. So you've got to be careful about the readmissions. I see it's in your metrics, but you just need to be careful how you interpret that. It's got to be in context.
For the ambulatory care, we have about 88% success rate at discharge within 4 hours of...
Do you want to come and present? Very good.
But
Very
that
good.
in particular is working
There's
quite
a
well.
lady here for the... Tentatively putting her hand up, looking for a microphone.
Hi, Monica works at Barnsley Hospital Children's Ward. I'd just like to ask as well, we're talking about the elderly population, but most of the people that come in hospital are not only always elderly, that bed block. You get people, obviously, for different reasons. I'm not going to mention it, but are we going to look into that as well?
Okay, so this is a fascinating area. So the biggest growth area for attendances has actually been in the 18 to 60-year-old group, not the elderly population. There is a steady growth, but actually the disproportionate growth, and actually there's some recent data, I think it's been published yet, so I'm saying this on camera, but if you look at patients who have walked into A&E, just over 20% of those patients who walk into A&E don't have anything done to them. This is not from hospital code data, this is from actually studying them. They don't have anything done that suggested they needed to be in the hospital. They didn't see a specialist, they didn't have an investigation, they didn't have any, had some advice, but that could equally have been done in their home or much closer to home. In children, it's 31%, so higher in children, and the reasonable anxiety. I mean, I'm a father of 5. We all get concerned, don't we? And so that's much higher in children. And so there are 2 things here, and I'm just going to move a slide on because I've got some. So it's not about. There's 2 things here. There's admissions and there's attendances. And I hear you said there you're an admission avoidance program. And that's quite different from an attendance avoidance program, and we need to understand that. And the media and everybody gets this very confused. But this here is summer and winter. So attendances are high in the summer and admissions are low. The hospitals are actually quieter in A&E. I know it doesn't feel like it, folks, but quieter numerically in the winter because attendances go down, but admissions go up. And this is so we know that if for every 1 degree the temperature drops below 5 degrees Celsius, a cold day, there's a significant increase, 10% increase in the number of patients, elderly patients, who will develop breathlessness and seek medical advice. There's a 0.8% increase in the emergency admission rate. There's a higher rate of stroke. There's a 4 times higher rate of heart attack because of the cold weather. And that's what's driving that. So it's really important we understand what we're trying to do. So something like not transferring patients to hospital just because they need care, because they've had a tumble, but actually they could be supported in their home, is really important, because that will address your admissions. The bit we're talking about for children and the younger adults, then there are things around attendance. And in that Right Now society I talked about, this is why the 111 service has become popular, because people have that immediate reaction with the system. We've just piloted 4 sites and are rolling out versions of it, of a digital 111. So you can go online and you can basically go through the 111 process, but on your phone or your laptop or whatever. And at some point it may pop up and say, do you want to speak to a mental health nurse, or whatever. So it's a 111 system that is actually online, which will be another potential opportunity. We're testing that out because we don't know quite what that will mean and how people will use it. But there are 2 quite different things going on there. And that young adult population is using A&E far more. And we have to really understand why that is. Because that's a group you really thought they want an answer which we're obviously clearly not giving them at the moment. 111 is partly, but it's certainly not going all the way, so we've got more to do there. And for those of you who are really like numbers, the green is respiratory admissions to hospital. We go from 1,000 admissions a day to 2,000 admissions a day between November and February every year. For those of us who work in hospitals, I would reflect how we change our services to meet that. And if you look, the only service that goes the other way is musculoskeletal, trauma and orthopaedics, that are quieter in the winter. So you were talking about people working on different wards. There's an answer here that perhaps the OTs and the physios in trauma and orthopaedics in the winter, perhaps we should be reducing some of that service, and we should be moving to ambulatory respiratory care options and things. There's different ways, and we're not very good at seasonal planning in the system. But if you haven't had your flu jab, just reflect on that graph. Who hasn't had their flu jab? Who hasn't? Look at that. You see that? Look, everyone's had the flu jab. I'm impressed. Not that we're necessarily going to get flu, because, by the way, this is where the media runs us wild. So the flu in Australia is the flu we had last year, and we don't get the flu that the Australians get. We get the Asian flu. So just don't believe everything you read in here.
Any more questions?
Oh no, now I'm in trouble.
No.
Okay.
I'm Dr. Krishnasamy, Associate Medical Director for the CCG. My question really is, at the moment, currently the systems almost are competing against each other in a current constrained financial situation, like hospitals having their own cost improvement plans. CCG allocation has been reduced, so we are under a significant massive QIP challenge,
Yep.
and public health funding has been cut down as well. So there's always a constant firefighting, if you like, with the rising demand on the backdrop.
Yeah.
So there's a public perception that, particularly with the ACO and ACS that's coming in the horizon with the STP, how do we genuinely make it as a sustainable transformation plan and not actually as a Sheffield takeover plan?
Yeah, I'm sure there are local views about that. And as I said earlier, we're starting. You're having, and I've witnessed it today. You're having relationships and just building relationships and having discussions between organisations that just didn't happen. There is no doubt. Over time, we have fragmented the NHS. We've got competing payment systems. Clearly, we have a government that's decided how much we spend, and we just have the responsibility to spend that in the most effective way for our patients. So this is all about relationships. I think the discussions I've listened to today and what I understand about the system, and it's going to take some courage to take it forward, but it will be about moving to a system where the organisations are coming together, not just the providers, but the commissioners as you are representing. Ultimately, I think we need to get to a system where we have sort of an open book agreement, so that those organisations are not competing financially by showing each other how they're spending and what their problems are. So I'll talk about the payment model. What it means is, so if a hospital is paid on activity, then everything is in activity. Yet we know that typical acute ward in hospital, 75% of the costs of that ward are fixed in year. They're not fixed costs as in, it's a building, but they're fixed costs because you can't really change the staffing complement within a financial year for planning. So 75% of those costs are fixed. If you go to A&E, it's about 85%. If you go to an ambulance service, 90% plus of their costs are fixed. Because by the time they've bought all their vehicles, they've got their dispatch room set up, they've got their call centre operational, and they've got all their paramedics. They've spent most of their money. The last bit's only on petrol and a bit of drugs, to be honest. So why do we pay them on activity? So if I take a patient away from an acute trust, 75% of what comes out when I take that patient's payment out is the core money the hospital needs to run, which just doesn't make any sense. So the hospitals, with the control targets and financial restrictions, find it really difficult to become flexible and say, look, we'd really like to move our patients into the community and do the right thing, but I just can't because I'm broke if I do. And then if you go to social care and community care, as I said, February, we're all in trouble in the hospital and say, look, please, can you move some patients out quicker? They're saying, well, I made my allocations last April. I haven't got any more flex. Can you give me some more money? So part of where I think the sustainability will come is number one, over above all else, will be the relationships between the organisations. And it will be the brave leaders who continue to talk when it gets tough and don't go back into their closets and silos. Number two, it's around information sharing so that everybody understands that this is a system-wide issue. That's patient information as well as operation information. Number three is around workforce. Let's not compete over the workforce. Let's not train someone here and steal them over there. Let's have an agreement how we best make this workforce that we've got in South Yorkshire and Bassetlaw best work for the system. And then the final one is that payment model that becomes a sustainable model. And we have done some work, and I'm very happy, you mentioned it earlier, to share with you an alternative payment model that I have to say it was my idea, so I won't yet take any credit because it's not been fully tried anywhere. But when I presented it to the NHS top finance team, the idea that some orthopaedic surgeon was telling them how to fund the NHS, you can imagine that went down like a lead balloon. And I don't normally do presentations and not get a reaction. You may have a choice about that. But I presented to that group, and at the end of it, I just got absolutely stone silence. I got no body language response whatsoever. And I just walked out and I had no idea. And I said to the Deputy Director of Finance in NHS England, what happened? And he said, I don't know. He said, I just don't know. Anyway, about 3 weeks later, I got this email that said, we've been thinking about it, and you might have got a point. Can we have another chat? But it was this real reluctance that somebody clinically who saw the system-wide problems, because they were seeing either global problems or organisational problems, and I was saying, no, the funding model's in the way here. We can do something different. So that is out there, and we can certainly link you up with that. But I do think we'll need to move to that, because when we started to try and put the systems together, the clinicians come together quite quickly to understand the advantages in the broader sense. Operationally, it makes sense to people who run the operations. And I think once the clinicians and operationally, they get it and they can do the local version of it, you can find that most of the patients and the public will understand where you're trying to get to. It's the finance directors, when they're sat in a room, have the biggest problem saying, well, that's my bottom line, that's my control total, how do I move from here? And clinicians can bring in the clinical risk and say, this new system, we can deal with that clinical risk, we can reduce it, we can make it. Operationally, they can deal with the risk, but somehow the financial risk sharing, which will inevitably appear in the current system, needs to be addressed. And so there's a different way to do that.
Okay, thank you very much indeed. Any further questions?
About an hour ago? What's the time now? Oh, well, okay.
There's nothing wrong with finishing early.
No. I thought I might have finished an hour ago.
I just think you've seen it today with different professional groups talking like they've never talked before, and I think this is an exciting time. And I think it's been the most inspirational talk we've had for a very long time. So I think we just have to thank Keith for his time. He's been with us all day and evening, and he's going to Leeds tonight. He's not going home to Oxford. So I want you to give him a great round of applause, and thank you very much, Keith, for your time.